So in this section, we'll look at how to approach the undiagnosed patient with abdominal pain. And this symptom is important because it has a large number of differential diagnoses. You're going to need to approach these patients with a systematic approach, take a competent history and perform a thorough physical examination, and then use simple and appropriate investigations to rule in or out your list of differentials. And you're going to need to do all of this well, because while many of your patients will have a benign cause for their abdominal pain, some will present with serious causes, with serious morbidity and mortality that will require quick surgical intervention, which could be life-saving. So let's start by thinking about pain. And more specifically, let's start by thinking about the two different types of pain. You're going to need to be able to recognise the vague and poorly localised visceral pain caused by distension of the intra-abdominal organs, obstruction of a tube like the bowel, biliary tree or ureter, or spasm of the smooth muscle that lines these tubes. And then you're going to need to be able to recognise parietal pain, which is usually more localised and caused by local inflammation of the parietal peritoneum. So to understand this properly, I'm going to quickly run through the important and clinically relevant anatomy that will give you some background to the origins of the two types of pain. And you might want to stop and hop on over to our sister site, Teach Me Anatomy, for more information at this point. So in the beginning, in the fetus, the abdominal cavity was lined by a big balloon of simple squamous epithelium called mesothelium. This is the peritoneal sac, and the fetal gut tube pushed its way into the peritoneal sac and took with it its blood supply and nerves, which become trapped between two layers of the mesothelium. We call this mesothelial sandwich the mesentery. And although the peritoneum is one continuous layer, different parts of the peritoneum will go by different names. I've already alluded to the mesothelial sandwich, which we call the mesentery. But the part of the peritoneum which is adherent to the gut wall is called the visceral peritoneum, and the part adherent to the inside of the abdominal wall is called the parietal peritoneum. And understanding all of this is important when interpreting the different types of abdominal pain. Organs that are covered by visceral peritoneum and supported by the mesentery are termed intraperitoneal organs, and any pain from these organs will be represented on the anterior abdominal wall. Whereas organs that lie behind the peritoneum are called retroperitoneal structures like the kidney or the ascending and descending colon, and pain from these structures will be represented in the back. So imagine this gut tube, and before all the twisting, folding and dilatation, the gut tube was a single midline structure. It eventually will develop into the foregut, midgut and hindgut. The nerves responsible for the visceral pain are afferent nerves that go from the gut tube to the spinal cord, and we call them the general visceral afferents. There are two reasons why visceral pain is vague and poorly localised. First of all, for every painful stimulus of a visceral structure, multiple afferent nerves will fire, and they'll go into the spinal cord at various levels, so you can't tell at what height you're feeling this pain at. They'll also go into the spinal cord from the left and from the right, so the pain will actually be represented as a midline structure. The brain will tell you that foregut structures are felt here in the epigastrium. Midgut structures are felt periumbilically, and hindgut structures are felt suprapubically. The last thing I want to mention about visceral pain is it's often associated with strong autonomic reflex phenomena such as vomiting, sweating and tachycardia. The nervous supply to the parietal peritoneum is entirely different, and it will come from a similar pattern to the nerve supply in the abdominal wall, and it will follow the dermatomal distribution. The pain is much more localised because there's only one specific nerve route that's being fired. It's entering the spinal cord at one specific site and on one specific side. So to tie all that together, and before moving on to the clinical aspects of this topic, the best way to understand what we've talked about so far is to look at the classic textbook definition of acute appendicitis. The appendix is a midgut structure, and due to distension, obstruction or spasm in the early stages of the disease process, the patient will feel a vague achy pain around their umbilicus. It will gradually get worse and it might be associated with vomiting. This is the visceral pain of acute appendicitis. But as the appendix becomes bigger and inflamed, the inflammation will start to spread through direct contact with other structures. When the adjacent parietal peritoneum becomes affected, there will be a small area of localized peritonitis, and the patient will feel a more specific pain, which is localized to the right iliac fossa, particularly over McBurney's point. So you can find more information about the presentation of acute appendicitis elsewhere on this site. But for now, hopefully you understand the vague visceral pain and how in appendicitis it becomes more localized parietal pain. And having understood that, we'll now move on to real clinical life and think about how we approach a patient with undifferentiated abdominal pain. So as we discussed earlier in our session on the generic approach, it's best to approach your patient with a list of differentials already in mind. Have a think now and think about how many types of abdominal pain you can think of and how you might structure that in your mind so that when you're faced with a clinical situation, whether it be an exam or in real life, how are you going to come up with your list of differential diagnoses to guide your next step? So, the differential diagnosis of abdominal pain. I like to think first of inflammatory causes. You can split these into medical causes like hepatitis, cystitis, or surgical causes like all of the causes of an acute abdomen. For example, inflammation of the foregut structures such as cholecystitis, cholangitis, or pancreatitis. In the midgut we can think about appendicitis, and in the hindgut we can think about diverticulitis or distal colitis. It's important not just to think about the inflammatory causes, of course, but you can also think about other disease processes such as perforation, obstruction, ischemia of the viscus. And we'll go into more details about these a bit further on. And finally, you can think about hemorrhage, particularly in the early post-operative patient, but also in A&E with the older gentleman presenting with back pain and shock due to a ruptured abdominal aneurysm, or the young woman that may be presenting with a ruptured ectopic pregnancy. So while I've just used disease processes, inflammation, perforation, obstruction, ischemia and hemorrhage, you can think of this in other ways. And I want to give you some examples now of different structures to scaffold your thinking. So some clinicians will use a system such as a surgical sieve to generate a list of full and inclusive possible differentials. And there's one that we've used as an example in our generic approach presentation. But you might also want to think about your patient with abdominal pain in terms of systems. So you can think of gastrointestinal causes of abdominal pain, urinary, vascular, gynecological. Before moving on, I'm going to mention that it's important to be aware of some of the other important diagnoses that could present with abdominal pain that are easily missed, such as an inferior myocardial infarction that is actually presenting with epigastric pain, or a strangulated inguinal hernia or testicular torsion, which was presenting with lower abdominal pain. So with our differentials in mind, I think we're all set and ready now to approach our patient. And remember, as always, we need to first perform an end of the bedogram and decide on how sick our patient could be. After this, we may need to go down an A, B, C, D, E approach. Or if we've got time, we can now do a more considered history and examination. So with the patient's consent, let's think about history and examination, which you can start almost simultaneously. As you ask questions, you need to be observing the patient, and you're trying to look for objective signs as to how bad this pain is. Are they just unable to answer your questions because the pain is just that bad? Did you have to give them some pain relief before you could get going? Are they writhing around on the bed because they're unable to get comfortable? Or are they laying really, really still? And even if you used to nudge the bed, it would be too painful for them because they're truly peritonitic and any movement would be uncomfortable. As a bare minimum, we need to ask questions that cover our 5 areas. So these include the onset, progression, severity, associated symptoms, and risk factors. But with any pain history, there are also other ways of thinking about how we might approach the history. And some clinicians will use mnemonics such as Socrates, OPQRST, or Squitarbs in order to avoid missing important details. So, I like to use Socrates, which stands for site, onset, character, radiation, alleviating, timing, exacerbating, and severity. So I always ask, where do you feel the pain worst? And the patient at this point will normally point to where they feel the pain is at the most severe. And you can ask their consent before you start palpating the abdomen while you continue to ask questions that might be distracting. And you can say, can you remember how the pain started? Did it come over a few minutes, hours, or was it more like days? How would you describe this pain? Give them a few examples. Is it tight? Is it stabbing? Is it a burning pain? Is it always there, or does it come and go? Does it always stay there, or is it moving? Did it start somewhere and move somewhere else? Is there any radiation to this pain? Do you think this pain's getting better or getting worse? And if it's getting better, what's made it better? And if it's getting worse, what do you think makes it worse? How long have you had this pain now? You'll immediately be less worried about a pain that a patient presents with that's been going on for years. It's no less important, but it's less serious for you to act quickly in these patients. But if you've got a short history of severe abdominal pain, then you need to be thinking about life-threatening causes. And then lastly, ask, do you have any other symptoms? And at this point, after letting the patient offer up any other symptoms, you then need to lead them and ask them directly, is there any nausea and vomiting? Do you have any loss of appetite, diarrhea, chest pain, back pain, urinary symptoms? And in a female patient, how can you end the history there without asking about their last menstrual period and whether they've suffered any abnormal vaginal bleeding or discharge? And if there's any possibility that that patient could be pregnant. When you go to lay your hands on the patient, don't jump straight into the abdomen. It's important that you perform a quick general examination first to gain an idea of the patient's current clinical status. This doesn't have to be long, but feel their pulse. Are they tachycardic? Look in their mouth. Are they dry? Is there a bowl full of vomit by the bedside table? Before you palpate the patient's abdomen, ask them to point where the pain is worst and then palpate the entire abdomen, but start furthest away from the pain first. You should be systematic with your palpation and ensure that you've palpated each of the 9 areas of the abdomen. The first time you go round, you're just doing a superficial pain survey. You don't want to cause the patient any unnecessary pain, but you do need to decide whether the patient's tenderness is all over and generalised, or whether you can map it out to a particular region. After you're satisfied, you know where the patient's tenderness is located, you should decide whether there are any guarding or rebound tenderness features that may make you think of peritonitis. So guarding is where you feel the patient's abdominal musculature contracting under your hand. And some patients will guard voluntarily, but you're more interested in involuntary guarding. And it can be difficult to tell these apart, which is why mixing your history with examination and trying to distract your patient, going away from that area and then coming back, you can get a feel about how tender they are in that area. And rebound tenderness is where you gently push down on the patient's abdomen, then quickly release. And it's said to be a sign of peritonism because the patient will experience more pain when you let go as the parietal peritoneum pings back into action. So we now move on to think about site and radiation of pain. And this is one way of thinking about abdominal pain, is classifying it into the 9 areas of the abdomen. So just by way of a few examples, and there are others on the screen now, you can think about right upper quadrant or right hypochondrium pain being hepatobiliary system. You can think of epigastric pain being gastritis, peptic ulcer disease and pancreatitis. And you can think of things in the left hypochondrium by thinking about the pancreas again, but also about splenic trauma or splenic rupture or infarction in a sickle cell patient, for example. Think about the loins and think about particularly loin to groin pain as being any cause of ureteric obstruction. And with ureteric obstruction or obstruction of any tube, you need to think about causes in the lumen of the tube, like a stone, in the wall of the tube, like a cancer, and outside of the tube, causing external compression, such as retroperitoneal fibrosis, causing external compression of the ureter and causing ureteric colic, which radiates loin to groin. Think of periumbilical pain. Remember, this is visceral pain of any of the midgut structures, but also you can think about AAA, constipation and small bowel obstruction. In the right iliac fossa, appendicitis of course, but think about Crohn's disease with a patient presenting with terminal ileitis. Think about a strangulated inguinal hernia, torsion of an ovarian cyst, salpingitis, ectopic pregnancy, or testicular torsion. The same gynae and testicular torsion diagnosis can be made with pain in the left iliac fossa, but you also want to be thinking about diverticulitis, colorectal cancer causing obstruction, sigmoid volvulus, ulcerative colitis. And suprapubic pain, you need to be thinking about cystitis, pelvic inflammatory disease, but also an atypical presentation of appendicitis with a pelvic appendix. So after you've really defined the pain and the features of the pain, and you've got a good impression of what's going on, you need to ask about the presence or absence of associated symptoms. Positive or negative findings here are absolute history gold because they're just about to give the game away. So if someone presents with GI upset, whether it's vomiting or what, you need to be asking about all of the other GI symptoms. If someone comes with vomiting, how can you not ask about diarrhea, constipation, blood, whether it be in the vomit with hematemesis or in the stool as melena or as fresh PR bleeding? And also ask about abdominal distension. If someone's coming with right upper quadrant pain and you're thinking hepatobiliary pathology, then you need to ask about jaundice. If you're thinking UTI or urological pathology, you need to ask about dysuria, but also oliguria or even anuria. And if you have a female patient and you're thinking this might be a gynecological problem, you need to ask about their last menstrual period, when that was, and the timing of their symptoms with the menstrual cycle, as well as if there's any vaginal bleeding or vaginal discharge. You also need to think about vague patterns of disease. So infection in general, you need to ask about pyrexia and malaise with a short history. You need to ask about sick contacts and foreign travel. With malignancy as a general concept of disease, you need to ask about weight loss, fatigue, and loss of appetite with general deterioration. And if you're thinking about bowel obstruction, as we've already said, you need to be thinking about bilious or feculent vomiting. You need to be asking about absolute constipation to feces and flatus, and also about abdominal distension. Also, other things to be on the lookout for would be Charcot's triad. So you need to be asking about the presence or absence of fever, right upper quadrant pain, and jaundice, which is obstructive, with dark urine and pale stools. And shock as a general concept. So thinking about tachycardia and palpitations, thinking about looking for hypertension, and also trying to ascertain a serum lactate. So once you're happy that you've fully explored the history of presenting complaint, you need to make sure that you've asked about the patient's past medical and surgical history, asked about similar episodes of this sort of pain, and also whether they've had any previous surgeries. So that appendicitis that you're thinking of is suddenly a lot less likely in someone that's already had an appendicectomy. Ask them about a history of inflammatory bowel disease. Ask whether they're known to have gallstones. They might have had an abdominal ultrasound before, which you can look up, and you might know whether they've got gallstones there. Ask about a history of alcohol abuse, because this is a big risk factor for peptic ulcer disease, gastritis, and pancreatitis. And also look for features of atrial fibrillation with an irregular pulse and a characteristic ECG, because this patient with generalized abdominal pain may actually have mesenteric ischemia. To wrap up the history, you need to make sure you ask about the drug, family, and social history, because they're really, really important for your patient with abdominal pain. To start with the drug history, it might be useful to know what the patient has already had in terms of analgesia. It will give you an idea of how bad the pain is, but it also lets you know what else you need to try now. What's your next prescription going to be? Patients with chronic abdominal pain have very complicated analgesia regimes, which might also involve patches. So you need to be careful when prescribing opiates on top of that. But also in the drug history, ascertaining that someone's got a history of non-steroidal drug use will be useful if you're thinking that they might be at risk of gastritis or peptic ulcers. And in someone with right upper quadrant pain, it would be useful to know if they're on any drugs which could be hepatotoxic. The social history is always important because it gives you the opportunity to understand more about your patient as a person and how they live their lives. And the social history is the history that's going to help you rationalise decisions regarding surgical intervention in some cases. Have a look at our presentation on the generic approach for more details about this. But for now, remember that abdominal pain is important to know about your patient's alcohol consumption and smoking, which are both risk factors for peptic ulcer disease. Having assessed the patient, we're now in a position to talk about our investigations and our initial management plan. Before we do, I need to stress how important it is to ensure that you provide adequate analgesia for your patient at the earliest opportunity. This is something that you may have already started, but if not, this should be your first priority. And it's also important that you provide an adequate analgesic review at a later stage to ensure that you've got this right. Without further ado, let's talk through our 5-point system once again for thinking about investigations. So, starting with bedside investigations, it's important that we monitor our patient. We look out for signs of shock, which immediately starts us thinking about intra-abdominal sepsis or perforation, as well as hemorrhage, maybe from an ectopic pregnancy or a ruptured AAA or spleen. The next most important bedside test is the urine dip. If you're already thinking the patient in front of you has renal colic, then seeing a lone trace of erythrocytes on the dipstick will help to confirm your thinking. Many radiologists will give you a difficult time when it comes to requesting a CT-KUB if you can't tell them what's on the dip. Also at the bedside, why not get an ECG? I've already mentioned that acute myocardial infarction can masquerade as an acute abdomen, but abdominal pain patients are also sick and they're predisposed to arrhythmias such as AF, and an ECG is an important requirement before most anaesthetics. And we also need a venous blood gas. Now I include this in bedside tests because near-patient testing is becoming more and more available. A venous blood gas will be a good yardstick for how sick your patient is. Lactate is a sign, of course, of end organ and tissue hyperperfusion and shock, but there are also a number of useful parameters on that blood gas which can inform your initial management, such as the blood glucose, hemoglobin, and electrolytes. So, blood tests now. A standard panel of abdominal pain blood tests will include a full blood count, CRP, USNEs, liver function tests and clotting. But also, let's not forget an amylase. It's important though that we never request tests blindly, and you should be able to rationalise or justify your choices. A full blood count is useful because the hemoglobin may point to chronic blood loss, and if you see a microcytosis associated with anemia, then you'll be thinking about malignancy as a possible diagnosis. Whilst the raised white cell count and CRP and platelet count, they're all acute inflammatory markers, and they'll strengthen your clinical diagnosis of infection or inflammation. If these are normal and you're already thinking that the patient might have benign pathology, then it will strengthen your decision to send them home with a review at a later date. Urea and electrolytes are important because they'll help to identify acute kidney injury in the shocked patient. But also remember to look for GI bleeding in the patient with an isolated rise in their urea. And we'll explore this more when we cover our session on GI bleeding. A rise in the alkaline phosphatase or bilirubin will strengthen your clinical diagnosis of biliary obstruction, and you'll want to proceed quickly to ultrasound scan to find that gallstone or that mass which is causing the problem. Clotting is a pre-op essential, and if there are any concerns or if the patient's on anticoagulants, clotting is a reasonable request. Lastly, an amylase. Although an amylase can be high in a variety of different pathology, a super high amylase is a diagnosis clincher, and you'll know that your patient has acute pancreatitis. At this point, you'll then need to do an ABG to define the level of hypoxemia and a corrected calcium, because both of these are needed for prognostic scoring in this condition. Number 3 is microbiology. And in terms of microbiology, if you suspect the patient has sepsis, you should culture everything. Culture the blood, culture the urine, culture the sputum, and swab any wounds or ulcers. Thinking about imaging and specialist tests, it's worth noting that this is not really the remit of this presentation to cover in an extensive way. But if you're a junior doctor, then there's going to be a limit as to what you can request. But in simple terms, you should request an erect chest X-ray for any patient that has severe abdominal pain, because they may have air under the diaphragm, which would show that they've had a perforation. And you should also request an abdominal X-ray for any patient that you suspect has bowel obstruction, or in the ulcerative colitis patient presenting with severe pain that you suspect may have toxic megacolon, because these are surgical emergencies. And you should think about ultrasound scan in the first instance for hepatobiliary or gynecological disease. Lastly, CT abdomen pelvis or CT kidney ureter bladder are useful to define a range of pathology, and you may well go down this route following senior review. In the patient presenting with abdominal pain, of course, there are specialist tests available. These will include ERCP and MRCP for biliary obstruction, or even laparoscopy to have a look inside to see what's going on if the diagnosis is in doubt. So you've just seen your patient, you've done your history, you've done your exam, and you've thought about a few simple tests. But before you pick up the phone and panic, remember that there are a few simple things that you can do to improve any surgical situation. And you should go through your 5-point system. Does the patient need oxygen? Well, most critically ill patients do, and you should aim for SATs of 96 to 98% in someone that's not known to retain CO2. If they are, aim for SATs of 88 to 92%. Next, think about fluid balance. Do they need IV fluids? Start off with a bag of Hartmann's or normal saline. It doesn't really matter, but remember to chase your electrolyte results and tailor your fluid therapy depending on what their electrolyte levels are. And ask yourself at this point, does your patient require a urinary catheter? Of course, we don't want to be giving a urinary catheter to everyone because they're associated with infection. But if urinary retention is the cause of this patient's abdominal pain, then I think the patient will thank you for placing a urinary catheter. And if they're critically ill, you may well require that catheter for urine output monitoring. Drugs. We've already discussed the importance of analgesia in this presentation. And in the first instance, make sure that the patient has had some paracetamol. But with moderate pain scores, you need to start adding in codeine. And with pain scores above 7 out of 10, you need to be thinking about morphine. Before prescribing a non-steroidal anti-inflammatory drug, be sure to rule out shock, because these drugs will inhibit dilatation of the afferent arterioles in the kidney, and they could tip that patient over the edge and precipitate renal failure. However, PR preparations of non-steroidal drugs seem particularly effective in patients with renal colic, as anecdotally, and you should consult your local trust guidelines for dealing with acute pain. Our last drug is antibiotics and antiemetics. And if the patient's vomiting, of course, give them an antiemetic because they're an aspiration risk potentially. You may well need to place an NG tube. And in terms of antibiotics, you need to be thinking about your local trust guidelines to decide on what's most appropriate. Number 4, VTE prophylaxis. Of course, this is important, but discussed elsewhere on the site. And number 5 is escalation. Escalation means achieving the right person at the right time at the right place. Or in other words, it means that you need to give due consideration as to whether the patient in front of you is safe in the current clinical area or needs to be moved to a higher dependency area. It also means you need to consider a discussion with a more senior doctor soon after you've seen the patient, if the current clinical situation is extending beyond your competence level. So, for example, if you have a patient in front of you and you suspect that they've got peritonitis and they're going to require an operation, this patient needs to be escalated to at least a surgical registrar who would be able to take that patient to theatre if needs be. So there we have it. Thanks for staying with us. We've reached the end of this section on abdominal pain. We've covered the approach to history, examination, investigations and management, and we hope that this will be a useful resource to pull together some of the other sections on the site. Join us again sometime soon when we explore how to approach a different clinical scenario.